Hi, good morning, everyone. It's 9 o'clock Pacific, and for those of you who are on the East Coast, it's 12 p.m. I'm Manmeet Ahluwalia. I'm a medical oncologist. I serve as the Chief of Medical Oncology and the Chief Scientific Officer of the Miami Cancer Institute. I also work as the Chair of the CNS Working Group. And I would like to take this opportunity to introduce Lacey Craddock, who's my project manager, but going forward is going to be our liaison for the SWOG CNS Working Group. And you all will be getting invitations. We'll be meeting periodically every 6 to 8 weeks in between our meetings so that we can continue to do the work. With that, obviously, we have a packed agenda, and thank you to all the speakers for agreeing to speak today. We do have a unique situation where we have a hybrid meeting. I was scheduled to be in person in Seattle, unfortunately had a family situation, so I am virtual, as are a number of our speakers. But Dr. Chad Rastovan is there in person in the room, and Dr. Eric Wong and a number of other people. So welcome, everyone. Lacey, do you want to start sharing the screen? So Lacey Craddock is going to run the slides for everyone so that we don't go back and forth. Chad will be our first, Dr. Chad Rastovan will be our first speaker.
Okay. Yep, hold on 1 second.
So as I said, we have a packed agenda today. So we have 6 talks, and Dr. Chad Rastovan will kick us off, and he's going to give us updates in brain metastases trials. Chad, the floor is yours.
Great, thank you. So Chad Rastovan, nice to see you all. I'm a radiation oncologist at the University of Colorado, and I will be presenting just updates on 4 ongoing trials that have been endorsed by SWOG and or this committee. And so these are the trials: SWOG S1827 Maverick, NRG CC003, Alliance 07801, and NRG BN 009, and I'll go through the details of these. So next slide, please. Okay, so this first trial, this is the so-called Maverick Trial, or SWOG S1827. And this is a trial that I'm leading in conjunction with my co-PI, Dr. Paul Brown. And so this is a trial for patients with small cell lung cancer looking at MRI surveillance plus or minus prophylactic cranial irradiation. And it's a randomized phase 3 trial. And so here we have the schema for this trial. On the left, you see it's for small cell lung cancer, including both limited and extensive stage disease. Standard eligibility for PCI trials: no prior brain metastases and no brain metastases after finishing first-line therapy. And then it's a straightforward 1-to-1 randomization to brain MRI surveillance alone plus or minus PCI, stratified by limited versus extensive disease, immunotherapy, and performance status. The brain MRI surveillance schedule is every 3 months during year 1 and every 6 months during year 2, which is consistent with the NCCN guidelines. So all of these studies are standard of care. And the primary endpoint of this trial is overall survival with a non-inferiority hypothesis. So our hypothesis is that in the setting of active MRI surveillance, that any excess brain metastases that you might see without delivering PCI can be detected early and treated with effective salvage therapy, and that therefore this would result in no significant differences in overall survival. Next slide. And so some notes on where we're at with the trial and just some things to mention. So Maverick is the first randomized trial of MRI surveillance plus or minus PCI in limited stage small cell lung cancer. Probably the best evidence on this question in limited stage small cell is a meta-analysis from 1999 by Operin and colleagues in the New England Journal of Medicine. So getting quite old, and so it's useful to relook at this question in the MRI surveillance era. And it will also be an essential trial to resolve conflicting overall survival data on PCI in extensive stage disease, where we have 1 positive trial from Slotman and colleagues and 1 negative trial from Japan on the overall survival impact of PCI in extensive stage. So the trial was designed to prioritize low barriers to accrual any and all first-line therapy for small cell lung cancer is acceptable. The trial allows flexibility for the treating physicians. Hippocampal avoidance, PCI, and salvage stereotactic radiosurgery are welcome. We have flexible eligibility windows, and patients can enroll for up to 16 weeks post last cycle of chemotherapy. And our baseline approach is to allow dual trial enrollments wherever possible. So if a patient's on another trial or might be interested in a trial after the Maverick trial, we do our best to accommodate those things because we want to keep barriers to accrual as low as possible. In terms of progress, so the trial was activated right as the pandemic was kind of about to set off. But we've made good progress over the last 2 years. As of this morning, we're at 88 patients accrued. We have a high accrual goal for the non-inferiority endpoint that's in the range of 600 analyzable patients. And so we are looking at ways to try to reduce that accrual goal with statistical modifications to get it more in line with about 250, which we think we would achieve in the next several years. So that's still in process. And I would just mention too, for folks here on the call who have some of these other competing trials open, there's a couple of important NRG trials that have accrued really well. One is NRG CC003, and that's where all patients get PCI plus or minus hippocampal avoidance. And then there's NRG LU005, which is limited stage small cell getting chemoradiation plus or minus atezolizumab. Both of the trials have accrued extraordinarily well and should be done with their accrual over the summer. And so as those trials are closing, I just would invite people, if you have our trial open, to just keep screening for patients for the Maverick trial because there'll be more patients eligible now that these competing trials are successfully accrued. And if you had like the CC003 trial open, I hope that you'll consider opening the Maverick trial as a successor trial to that study. And if you have any questions or are interested in potentially opening the trial, please feel free to email me. That's my email address. Next slide. So then moving on to the second trial. So kind of in a similar space, but a bit of a different question. So this is the NRG CC009 trial. And this is also for patients with small cell lung cancer, in this case with known brain metastases. And this is a randomized phase 3 trial comparing stereotactic radiosurgery versus hippocampal avoidant whole brain radiation for patients with 10 or fewer brain metastases from small cell lung cancer. So we can just walk through the schema here. So small cell lung cancer brain metastases, randomized in a straightforward 1-to-1 randomization to stereotactic radiosurgery alone versus hippocampal avoidant whole brain radiation therapy to 30 gray and 10 fractions. The primary endpoint of this trial is time to cognitive failure using a standard battery of cognitive tests, and the sample size projection is 200 patients. Next slide. So some notes on this trial. So this is an exciting trial for us. It's being led by Dr. Vinay Gandhi and myself as the co-PI on this trial. It is to our knowledge, it's the first randomized phase 3 trial looking at stereotactic radiosurgery alone for patients with small cell lung cancer brain metastases. As you know, small cell has kind of been sectioned off as this kind of special disease where even though we've transitioned to stereotactic radiosurgery for limited brain metastases for most tumor histologies, small cell has kind of remained this one disease where whole brain radiation has remained the preferred approach. And part of the reason for this is people are concerned about more rapid CNS progression and worse outcomes if we withhold whole brain radiation. And for that reason, these patients have not been included in the large phase 3 trials that have evaluated and established stereotactic radiosurgery in the past. So this is an important trial because it's actually trying to address that question specifically for this population and to help to potentially establish radiosurgery as a viable option. This was activated last year. Currently, the accrual is at 20 of 200. But also note that patients on the Maverick trial in the MRI surveillance alone arm, if they do develop brain metastases, they can can't go on to enroll on this trial. So we've tried to harmonize these two trials together for folks who have both of them open. And this trial is open, and we're actively trying to accrue more centers. It's accruing, but slow and steady. And we would like to bring in more centers if you're interested in this question, which I think is a really important question. And again, if you have any questions about it, please feel free to reach out to me. Next slide. Okay, so moving on to our third trial. So this is Alliance A071801. And this is a phase 3 trial of post-surgical single fraction stereotactic radiosurgery compared with fractionated SRS for resected brain metastases. And the PI of this one is Dr. Paul Brown. And so this is, here's the schema, but just by way of background. So overall, when you have patients who have a brain metastasis that is large or symptomatic or in a problematic spot, sometimes we offer surgical resection. And there have been a number of trials that have looked at ways to improve surgical bed control that have helped to establish postoperative stereotactic radiosurgery as a technique to improve local control outcomes in the tumor resection bed. And so this has been established by some randomized trials. And in those trials, the approach was single fraction stereotactic radiosurgery. And this did show an improvement in local control, but the outcomes in terms of tumor bed control were still suboptimal, somewhere in the kind of the 70 to 80% control range at 1 year. And so there's this question if we could do better, if we could offer a different type of approach that would improve the surgical bed control. And one potential option is using fractionated stereotactic radiosurgery. And there is a collection of data, largely retrospective, but some small prospective data using fractionated radiosurgery to the surgical bed that has actually shown better outcomes in the range of 80 to 90+% tumor bed control. And so we have this question of really what is the best way to offer radiosurgery to the surgical bed, and is one way superior to another? And so that's how we get to this fundamental question. So in this trial, we have patients who have had a resected brain metastasis that's greater than 2 centimeters, and they're randomized to radiosurgery in both arms, but one is with single fraction radiosurgery and the other is with a fractionated stereotactic radiosurgery approach in 3 to 5 fractions. And the primary endpoint of this trial is time to surgical bed recurrence. Next slide. And so this study was activated in October of 2019. It's been endorsed by this CNS Working Group. It's accrued extremely well, and it's expected to complete its accrual potentially sometime over this summer, with a hope to analyze data potentially in summer of 2023. And the PI, Paul Brown, just asked us to remind those who are participating to please upload MRI imaging, as the primary endpoint is an imaging-based assessment for surgical bed control. Next slide. And then finally, the fourth trial that I'll talk about. So this is NRG BN009. And this is a phase 3 trial of salvage hippocampal avoidant whole brain radiation plus SRS versus salvage SRS alone for first or second distant brain relapse after upfront SRS for brain met velocity greater than 4 mets per year. So that's a mouthful. So I'll try to unpack some of that. So for patients who present with limited brain metastases, stereotactic radiosurgery has really become the preferred approach for treating brain mets in most settings. But it has been noticed and published on that sometimes in patients who have what's called a high brain metastasis velocity, that they seem to have worse outcomes. So brain met velocity is this concept, which is basically the number of brain metastases that you detect divided by year. And so some of the studies on this have shown that for patients with greater than 4 or greater than 13 brain metastases per year, that they tend to have worse outcomes, both for overall survival as well as neurologic mortality. And so there's this thought that, well, if these patients are more likely to die of their brain metastases, and they're developing brain metastases at a faster rate, is offering salvage radiosurgery again and again for those patients the best approach? or is that a patient who would actually benefit from doing whole brain radiation? And in this case, looking at a hippocampal avoidant whole brain radiation approach to decrease toxicity. So that's kind of the background. So then looking at this, this title again, so this is basically patients who have had radiosurgery before, and now they have new brain metastases. So it's a salvage situation, and it's a high rate of metastases, greater than 4 per year. And it's randomizing those patients to radiosurgery versus a whole brain approach. And so that's here's the schema for that. So greater than 4 brain metastases per year in the salvage setting after prior radiosurgery, and then randomized to SRS alone versus hippocampal avoidant whole brain radiation plus SRS. The primary endpoints is time to neurological death, and that has a pretty strict definition and layers of review to confirm neurological mortality by certain criteria. And the sample size for this is estimated to be 350 patients. Next slide. So some notes on BN-009. So again, it's brain relapse after course 1 or 2, greater than 4 brain mets per year. The included histologies for this are non-small cell melanoma, breast, renal cell, and GI. And there's a plan to actually add small cell lung cancer in an upcoming amendment. And patients may not have had prior whole brain radiation or PCI. So this trial was activated in December of 2020, and it's not accrued very well. The accrual currently is at 4 of planned 350. It has been endorsed by the SWOG CNS Working Group. And to help with accrual and some of the barriers that the investigators have seen, there's a plan to have an amendment that allows for whole brain radiation alone without SRS boost to make it more flexible in terms of insurance coverage. There's been some problems with that approach. So to kind of simplify the design. So anyway, this is a trial that's been endorsed by this group, and we do want to support it and try to help these investigators answer this question. If you have any questions about this trial, please feel free to reach out to me and I can connect you with the principal investigators. Next slide. And so those are all my slides for this morning. Here's my contact information. I'd be happy to answer any questions that people have either in the room or virtually.
Thank you, Chad, so much for the presentation and on all your amazing work in the field. Are there any questions for Dr. Rastovan?
Yeah, I have a plug as well as a question. So Andrew Brenner from San Antonio. So I just wanted to put a plug in for S2007, which is our SWOG study with sacituzumab govitecan for patients with brain metastases from HER2 negative breast cancer for patients who have failed radiation, surgery, or both. So that's active and recruiting, and we're only about 7 patients into the 40-something we need. And so that is actually a registration trial. So if that is a positive trial, then that will lead to a label change for SG to include brain metastases. So I really want to encourage people to, if they haven't opened it, to open it and to help us accrue to that study. And I guess the question is regarding the SRS for small cell. So at our institution, we're already using SRS based on the FIRE SRS study. And I think that was like a 700 patient randomized study. So how is the study that's being done different from FIRE SRS, or how does it add to that? Or is there additional questions that we're asking?
Yeah, absolutely. Great question. So the FIRE SCLC study was a study that I was involved in leading, and that was actually a retrospective study. So what that was looking at patients who had not had prior whole brain or PCI and who had small cell brain metastases, and then looking at the outcomes with a first-line stereotactic radiosurgery approach. And it was a retrospective study over about 20, 25 years, international, including Asia, North America, and Europe. And so we had this cohort of about 700 patients being treated with this approach. And then to provide outcomes, the comparative outcomes that people really are interested in, which is like, how does this compare to whole brain radiation to the standard of care? We looked at a published data set from Germany which was small cell lung cancer brain met patients getting first line whole brain radiation. And we had good detailed outcomes on their number of brain mets and their KPS and their outcomes and things like that. So then we took those two data sets. We took the small cell SRS 700 patients, and then we compared it to the retrospective whole brain cohort, and we did a propensity score matched analysis that matched them up for baseline characteristics, age, sex, number of brain metastases, KPS, all those things. And when we made that comparison, then in that analysis, we found that as we expected, whole brain radiation offered better CNS control. Time to event outcomes were longer in the whole brain radiation arm, as they always are, but this didn't seem to translate into an overall survival benefit. And in fact, the SRS patients did slightly better, which may be due to residual confounding. It's a retrospective study, but basically our takeaway from that study was that these outcomes with radiosurgery in small cell, at least in that study, in the FIRE study, looked really similar to the trade-offs that we see with the SRS versus whole brain question in other histologies. And if it's an acceptable trade-off in other histologies to say, okay, we offer SRS up front, and we know that you're more likely to have brain metastases in 6 or 12 months, but we can also salvage those, and we accept that trade-off. We're going to do MRI surveillance, and we're going to treat if something else comes up, because we believe that SRS is associated with similar overall survival and better cognitive and quality of life function. That's a trade-off we make all the time in the clinic. And the point of the FIRE study was to say, these trade-offs may be similar in small cell as well, and it's worth, considering. The big difference, here is that that's a retrospective study that's, done over a 2-decade period at all these different centers where we're pooling data. And of course, there's confounding and things that you can't totally account for in a retrospective study. And so that study provided the scientific basis for the NRG CC009 study to go through the approval process and to say, yes, this is really a ethical and legitimate question that needs to be looked at in a prospective randomized control trial to try to fully establish that therapy. And so, yeah, you're right that the NCCN small cell guidelines have been updated to acknowledge SRS may be an option in certain settings based on the FIRE study. But the field really does need to look at this prospectively to see how different the outcomes really are, and to see if these, our hypothesis that these trade-offs are similar, to see if that holds up in a randomized control trial. Yeah.
Thank you so much, Chad. If there are any other questions in the room, Chad, can you just moderate that? Because
yeah.
I have a couple of questions. One is about your Maverick study.
Yeah.
The treating physician can have a choice between hippocampal avoidance versus non-hippocampal avoidance, right?
Right.
And my second question is the PN009 study. The time of registering these patients is when? Is it after the first SRS or after the second SRS and follow the patient, or when the recurrence is there and then you register?
Yeah, great question. Yeah, so it's at the time of recurrence. So if you the inclusion criteria for the BN009 trial is patients who have had at least 1 or up to 2 prior radiosurgery courses for brain metastases, and then they're coming to the clinic with an MRI that shows new brain metastases, and you're in a salvage situation. That's when the patient could be offered the trial. So how are you going to treat that recurrence?
So
yeah.
Basically, you are selecting out the patients with the better prognosis, because I can think of that there are some of my former patients who need this SRS, and then when you get the next scan, it's too many to count.
Right.
So you are artificially selected out the very good prognosis versus intermediate good prognosis patients.
Yeah, I think I'm on the same page with you. So basically the trial is saying, so my clinic too, like I have patients who, every 6 to 12 months, They might have 1 or 2 brain mets pop up and you treat those and they go along, and then you see them again in a year and it's something similar. And that's a really good strategy for that patient. What they're trying to do with the BN-009 trial is they're trying to not look at that really good prognosis patient. They're trying to look at patients who are developing brain metastases much more frequently and with higher rates. So a brain met velocity of at least 4 per year in the salvage situation. So they're trying to look at a high risk cohort for exactly what you just said, which is there are some patients where you do, you offer your therapy and then they come back with innumerable brain metastases on their next scan. And what they're trying to do is say, if we kind of isolate that high risk, high brain met velocity population, is that a population that actually benefits from more aggressive CNS treatment in the salvage situation, where doing hippocampal avoidant whole brain radiation would actually lead to better outcomes, reduce neurological mortality in those patients. So they're not trying to look at the best prognosis patients who just develop 1 brain met every year or so. They're trying to look at the patients who are developing brain metastases faster.
But the way that I see it is that you're also not looking at the worst prognosis patients, because if there are innumerable brain metastasis, you are not going to put the patient into this trial random and risk the randomization to SRS everything.
Oh, okay. I see what you're saying. Yeah.
That was my question.
Yeah. Okay. Lacey, could we actually go back to the schema of the 4th trial? One more back. That one. Up, down. Go forward 1, please. Okay. Yeah, I don't think that they maybe go forward one slide. Oh no, that's good actually. So there is a brain met volume. Yeah. So it can't be innumerable with just extremely high volume disease. Very that situation. There is a limit on how bad it can be. Yeah. So that's a great question. Yeah.
Oh, brain met volume less than 30.
Yeah, so the worst scan, that you're kind of describing, this case where you just really wouldn't be comfortable randomizing them anyway. There's also, kind of an upper limit on, how much brain volume disease you can have and go on this trial. Yeah. And Mamie, I think that's all the questions here in the room.
Thank you so much, Chad, and thank you. I know Dr. Rastavan has other commitments, so I actually will volunteer Dr. Eric Wong to be the moderator in the room for the rest of the session, and because I'm not there. And to Dr. Andrew Brenner, Andrew, we will have periodic meetings, and everyone else who joined us later, we'll have periodic meetings of the CNS Working Group. And Andrew will invite you to the next meeting to give us a presentation of your trial. And then we'll see how we can all, continue to support it, since it's an important trial. So, and also in interest of time, we'll move on. We are a few minutes behind. So I would encourage all the future speakers to try to be closer to 15 minutes of talk time, so at least 5 minutes for questions and answers. Next on is Dr. Pallavi Tiwari, who's the Assistant Professor for Biomedical Engineering and the Director of the Brain Image Computing Laboratory at the Case Western Reserve University. Today, she's going to talk us about her work on artificial intelligence and computational imaging opportunities in neuro-oncology.
Thanks, Manmeet, and thank you everyone for this opportunity to present some of the work we've been doing in my group on artificial intelligence and computational imaging, and also, the work that we've done in the context of neuro-oncology. Could you go to the next slide? Thank you. So in a nutshell, I sort of wanted to provide a summary of the work. And as we are all aware, we're sort of moving towards precision medicine. And the goal is to develop prognostic and predictive tools that can allow us to tailor therapy for a patient based on their specific risk profile. So big focus of our group has been on developing these prognostic and predictive tools. If you could click on it. Yeah, and so as I mentioned, big focus has been on looking at computational imaging. And one advantage that these methods offer with computational imaging is that we use routinely acquired MRI scans and mine information from these routinely acquired MRI scans to address some of the questions around disease response, evaluating response to therapy, and so on. Next slide. So in a nutshell, we look at data that exists at different land scales, going all the way from radiology, pathology, and molecular data. And all of this has relevance in neuro-oncology and brain tumors. Next slide. And essentially the goal of, like I said, the goal is developing these quantitative imaging markers. So hypothetically, we assume that there is an ideal world setting where we could mine information. What it allows us to do is really capture the intratumoral heterogeneity that you could only see on imaging. Next slide. Lacey, would it be okay if I shared my screen? It might be easier because there might be a few clicks.
Sure. I think you can share. Sure.
Sorry about that. It's just easier if I did it. Okay, can you see my screen? Can you all see my screen?
Yes, we can.
Yes.
Pallavi.
Okay. All right, thanks. Yeah, so where I was essentially, what it allows us to do is capture intratumoral heterogeneity. And so to give you an example, let's say if we were to extract a biopsy from these two different locations, as we are all aware, this could lead to, different samples being acquired and different information that could be obtained and perhaps change the course of treatment for the patient. But with tools that we develop, we could perhaps sort of capture this intratumoral heterogeneity on imaging. And this field is known as the field of radiomics. And similarly, if there is pathology available, ideally spatially localized pathology, one could look at radiopathomic analysis and radiogenomic analysis. And by doing that, it essentially provides us with a cross-scale mechanistic understanding of these subvisual features that we get from our routine MRI scans. So this is just a summary slide to demonstrate that you could look at information across different lens scales, and what our group focuses on is developing both the deep feature extraction approaches using some of the newer deep learning approaches, but also handcrafted feature extraction approaches, which essentially focus on building the inherent biology of the tumor into the model itself. And then, a few clinical applications that we've been looking at, and I don't think I would have time to go through each one of them. So I just sort of have some representation, representative examples to demonstrate how computational imaging could have a role in SWOG, in clinical trials, sort of, developing these prognostic and predictive biomarkers. So the first example I wanted to share with everyone is this work that we started doing roughly 8 years ago now, actually in close collaboration with Manmeet and some of our other collaborators at other institutions, which was on distinguishing radiation effects in tumor recurrence. And, as you're all already aware, this is a very challenging problem, and, visual inspection is at best 50 to 60%. So when we started looking at this problem several years ago, when I started talking to my neuro-oncologist and neuroradiologist colleagues, I went with the idea, of course we have the algorithms, we can solve this, right? How difficult can it be? And very soon we realized it's a very, very hard problem. There's a reason why even expert radiologists struggle to distinguish the two conditions. So a couple of years ago, we then sort of switched directions. And as I mentioned, big focus of our group has been on, bringing in the underlying biology of the tumor itself into our modeling. So towards that end, we developed a new biomarker, as we call it. It's called Collage, which essentially looks at the entropy of localized gradient orientations on routine MRI scans. So essentially what you're looking at here, these arrows demonstrate the changes in intensity gradients on a per voxel basis on, this is a gadolinium enhanced even weighted MRI. And what we do then on top of it is we compute entropy values of these gradient orientations. To give you an example, if you look at this region right here, it's sort of nicely organized. The gradients are nicely organized as compared to this region where it's more chaotic. And this is represented in the entropy values. So we know from high school math, entropy is a measure of disorder. So if we were to look at the entropy of these gradient orientations, what we were consistently observing was for patients that have a recurrent tumor, tended to have much higher expressions of these entropy values as compared to patients that had a benign radiation necrosis. And then to further validate this, what we did was, we're also aware that on these post-treatment scans, there's a lot of heterogeneity, right? You could have in the same lesion, some tumor and some radiation effects. So we wanted to see how these collage features would do if you were to look at this spectrum. So this work was published a couple of years ago in AJNR, where we demonstrated that if you look at a patient that is, patient with pure radiation necrosis, so this is a head and neck patient who had head and neck tumor, but got cerebral radiation necrosis. So that was our control group. And then on the right is a treatment naive GBM. So we knew that there is no radiation effect in it. And then in between were sort of intermediate categories where we had predominant tumor and predominant radiation necrosis. And we had some other, 50-50 split as well. And again, we could observe that for patients that have more aggressive tumor, these entropy values were much higher compared to patients that had a benign radiation necrosis. So since then, we've expanded the study, and would be very interested in collaborating with my colleagues here on the study. Essentially, where we are right now is close to 90% accuracy in distinguishing radiation effects from tumor recurrence using routine MRI scans. And I think that's really the strength of this study, is that we don't need any fancy imaging. These are just routinely acquired MRI scans that you could ship to us. We could do the analysis and share the results with you. So far this has been retrospective, but Manmeet and I are an MPI on an R01 that's currently pending. So the idea would be to do it on prospective studies where we can demonstrate that that we anticipate accuracies staying close to 90% in our prospective analysis as well. And then again, this is some examples of the different features that we've developed in the group. So this is a 3D rendering of patient with brain tumor. Essentially in green, you can see the enhancing tumor, which we call the intratumoral region. And then you have the peritumoral region, which is, surrounding the tumor. And then the extratumoral region, which is the rest of the brain. So essentially, we have been looking at, developing features, not just from the enhancing region, but also incorporating features from the periphery and, some features that we've developed that, again, I don't have the time to go into, but I'm happy to discuss offline, where we look at the tissue deformation of the tumor and how that impacts the prognosis of the patient. And this is sort of some of our work on the correlative analysis that I was talking about, where we were looking at this is the IV gap study, as some of you may be aware, where they section the tumor into multiple subcompartments, and then for every tissue subcompartment, then they sort of quantified the extent of cellular tumor, perinecrotic zone, pseudopalisading cells, the characteristic pathological attributes for GBM. So what we had the opportunity to do was actually to do a correlation of the imaging features that we were getting with these pathological attributes. And interestingly, what we were finding was that these features, in this case, I'm showing collage features, these collage features from the enhancing tumor were highly correlated with pathological attributes corresponding to cellular tumor in perinecrotic zone, infiltrating tumor, hypoplastic blood vessels in cellular tumor, and then features that were coming from the periphery of the tumor were correlated with features of leading edge and hypoplastic blood vessels in leading edge. I also wanted to briefly touch on, just sort of give an idea of some of the work we've been doing in the radiogenomic space, where the idea is that if you have the genomic information available, can we do a cross-scale association of the imaging features with the genomic data? And so the first work we started to do in that space was for hypoxia. And as we are already aware, hypoxia is a major contributor of tumor heterogeneity and has implications in response to radiotherapy and associations with poor survival. And so what we did was for this study, this coming from the TCIA-TCGA cohort, where we had the corresponding omics data available. So using that omics data, we created a 21 gene hypoxia signature, and then we clustered our patients as having low hypoxia, medium hypoxia, and high hypoxia. And so for every patient, we would have this hypoxia index that we would compute using using this gene signature, the 21 gene hypoxia signature, and then we correlate these the hypoxia index with the radiomic features. So interestingly, what we observed was, when you look at this heterogeneity here, I'm showing the radiomic feature extraction, radiomic feature expression, where red means more heterogeneity. And so you can see that for features that sort of are linked with high heterogeneity corresponded to tumors that had high hypoxia, and so on with medium hypoxia and low hypoxia. And then with these imaging features, when we incorporate them for survival, you could see that they could distinguish short-term and long-term survivals for radiomic correlates of hypoxia. As an extension to the study, this was published a couple of years ago in Clinical Cancer Research, where we further demonstrated that not just for hypoxia, but other ontology pathways such as angiogenesis, cell adhesion, there are imaging markers that are associated with these specific omic signatures as well that could have therapeutic implications. And then this, I think, might be interesting for some of you, especially the ones who are looking at, sexual dimorphism in glioblastoma. So here, what we wanted to demonstrate is that even for the radiomic features that we were looking at, if you were to segregate them based on males and females, that you get better prognostic signatures instead of building a model that's sort of combined, that sort of looks at males and females together. So we did that study, and again, relatively small cohort, not a massive cohort, but even then we could demonstrate that when we separate these patients as men and women, separately sort of build model, a separate model for men, separate model for women, that we get improved survival analysis for these patients. And as an extension of that, we also looked at the radiogenomic analysis, where interestingly, what we were finding was for patients that have in the female population, where you were looking at patients that have improved survival, those imaging signatures corresponded to immune response, which intuitively makes sense, given that they would have elevated immune response, that they would have better response, they would have better outcomes. And then similarly for the male population, where we had more aggressive phenotype, those imaging signatures were correlated with more aggressive phenotypes on omics. We've also extended this work on digital pathology, where we were looking at scans from TCGA, and again we were able to demonstrate that there are specific phenotypic differences between men and women as observed on their pathology slides. Just in the interest of time, I'm going to skip some of these details, but essentially what I want to stress is that these radiomic features have a lot of potential. So we did this study where we were looking at comparing our radiomic classifier with two readers. This was for distinguishing radiation effects of tumor recurrence. And we were able to demonstrate that if you look at the consensus of the two readers, that the accuracy is 67% in distinguishing radiation effects of tumor recurrence. But when we bring in the model, the radiomic models that we're developing, that the accuracy goes up to 92%. And so just to put this in perspective, even for stereotactic biopsies, the accuracy is in the range of 90 to 95%. So using routine non-invasive MRI scans, we could get to accuracies that are comparable to stereotactic biopsies. And again, as I mentioned, this is an ongoing collaboration with GE through an R01 that's currently pending. And then lastly, I also wanted to bring in this clinical trial that will hopefully go on floor. This is in collaboration with Cleveland Clinic, where we intend to use the radiomic features to also identify sites for biopsy. So if there's interest, I'm happy to connect about this clinical trial as well. So to conclude, hopefully I'm able to convey in this short span of time with a lot of data that I showed that computational imaging has the potential to complement personalized prognosis, especially in the case of neuro-oncology with some of the very difficult questions that we try to address. And then similarly, we've been looking at radiogenomic and radiopathomic analysis, which is a big focus of our group. And I think some of these methods that I tried to capture in my quick presentation will have implications in clinical trials that are presented through SWOG. In fact, we've been working very closely with Manmeet, so we've been looking at some of the clinical trials that he's been leading in the context of immunotherapy to bring to bear some of these radiomic features in order to develop prognostic and predictive markers. So with that, I'd just like to thank the funding agencies and my group, and I'm happy to take any questions.
Thanks so much, Pallavi, for your presentation and all your great work. I think this presents additional opportunities for clinical investigators and others, to take advantage of what you and your group has to offer. So let's, in interest of time, are there any questions in the room first? We'll start there. And if there's a question, Eric, can you kindly moderate it and also repeat the question so that people who are virtual can hear it?
Sure. So Manmeet, I actually have a question, but let me ask the audience, does anybody have any questions? No. Okay, so I have a couple of questions. One is that the 89% accuracy, is this based on histology? If
Yes.
Yes?
Yes.
Okay, then my next question is the image segmentation. Is that an SPM-based image segmentation, and what is the voxel size?
So image segmentation, we take a sort of a semi-automated approach. We have a deep learning model that we've developed in our group. But as you're probably already aware, these segmentation models are not perfect. So we always have a radiologist involved who vets the segmentations, and those are the segmentations that are ultimately used for our analysis.
Okay, so this is not automated, or is this semi-automated?
Right. Yeah.
I see. Okay.
Yeah, just to get confirmation, and sometimes we have to clean up segmentation, so we always vet them through the collaborating radiologists.
Right. As far as I know, there's currently no automated segmentation program for that we can use to segment tumors for a brain without any structural abnormality. There is, and the frequently used one is SPM. And I think right now it goes up to SPM 12.
SPM, is that what you're saying?
Yes, statistical.
Yeah, that's not for segmenting brain tumor, right? That's just for segmentation of the brain structures.
Correct.
Yeah. So segmentation of brain tumors, there are multiple deep learning approaches that are that exist, and in fact, the collaboration that I'm talking about, we do have it's embedded into the model. So it's a web-based interface that we're working on. So the segmentation is embedded. It's just that it's not going to be 100%. So we just go and clean up the segmentations for the different compartments, like the necrotic core, enhancing tumor, and edema.
Okay, so in other words, when you do the segmentation, you only segment the tumor, you don't segment the rest of the brain.
No. Yeah, that's correct.
Okay, thank you.
Thanks, Eric. Any questions from anyone who's attending virtually? If not, thanks so much, Pallavi. And as I had mentioned before, we are now going to activate our CNS Working Group meetings periodically every 6 to 8 weeks, which will give people opportunities to interact more. And as our group grows, I think we'll present organic opportunities for collaboration. So with that, we'll move on with the agenda. Next, actually, I'm presenting. This is a concept that some of you have heard before. It's a trial of TRC-102 and Termizolamide in patients with newly diagnosed Mgmt methylated glioblastoma. And
Sorry, hold on one second.
that's okay, Lacey. If you want, I can present too.
Yeah, it's just I'm turning it back to the right slide. My apologies.
No issues.
Okay.
Yeah, perfect. Thank you.
Mhm.
So this is a combination of TRC-102 and Termizolamide in patients with newly diagnosed Mgmt methylated glioblastoma. It's a group effort. A number of the people are on the call today, so thanks for all your support on this. This group already knows this. Glioblastoma is still the most common type of primary brain tumor. Despite all our work, less than 5% of patients are alive at 5 years. We all know the hallmarks of this disease and the WHO classification, and we have seen some recent changes. In our last meeting, Dr. Herbensky had actually given us an update on the new WHO classification, and we'll re-invite Craig in one of our working groups meeting as we see what it means for us as we design the next trials. Next slide, please. Again, you know this, and this is why we are here. The way we treat our patients should involve clinical trials. So obviously, big thank you to all of you who do this on a daily basis. And as you can see, we are in glioblastoma. We are one of the rare tumor types where it's recommended that we consider a clinical trial, which is preferred to eligible patients even over standard of care. Next slide, please. It's not projecting well. Can you hit one more click? Okay, you all are aware of this data. So move on, Lacey, to the next one. So this is all basically that for some reason it didn't transcribe well, but it basically is the benefit of temozolomide is mostly in Mgmt methylated patients and it's not in unmethylated patients. Next slide, please. So this is the concept based on some of the prior work that I and several people across the country were involved with, which was a trial of TRC-102 and temozolomide in refractory glioblastoma. This was a study that we ran out of the Adult Brain Tumor Consortium when that existed and was one of the CTEP supported consortiums. Next slide, please. And this was actually based on work from Stan Gerson and his lab at Case Western, who basically was the guy who founded this drug called TRC-102. So you all know that when we give patients temozolomide forms 0,6-methylguanine, 7-methylguanine, and 3-methyladenine DNA adducts, of which the 6-methylguanine DNA adducts are actually repaired by Mgmt. And as I alluded, the patients who have Mgmt promoter methylation are the ones that get benefit from temozolomide because they do not have this repair enzyme. But we also know that the 7-methylguanine and 3-methyladenine adducts are actually removed by the base excision repair pathway. And we do know from work that N-methyl purine DNA glycosylase is the first step in the base excision repair and pathway. And then TRC-102 is a base excision repair inhibitor that binds to the apurine side that is created through the action of MPG. And essentially what it means is if someone, you combine these two therapies of temozolomide and TRC-102, especially in an Mgmt methylated patient, you can actually give them 2 hits. First is through the Mgmt promoter methylation where they lack one repair enzyme, and B, the other repair enzyme is the base excision repair pathway, and you block that with TRC-102. And this was basically exemplified in this orthotopic xenograft model, unpublished work from Andy Sloan and his group at the University Hospitals Case Medical Center, where they actually showed that the combination of the 2 therapies led to a much better survival compared to either of the 2 therapies. Next slide, please. So on the basis of this, we ran a phase 2 trial of patients with glioblastoma in first recurrence who was bevacizumab naive. And the primary endpoint of the study was objective response rates. Secondary objectives or endpoints included progression-free survival at 6 months, overall survival. We had some exploratory objectives, including looking at the treatment efficacy, looking at the tumor expression of N-purine DNA glycosylase, which is the first step in that pathway, and Mgmt status. Next slide, please. So essentially what we did in this 19-patient study, unfortunately, was found out that when we treated the patients with a combination of TRC-102 and temozolomide, median overall survival was 11 months. There was no responses seen. Overall median progression-free survival was 2 months. And the PFS6 rate was 10.5 months. In summary, this is nothing different than what we've seen with any of the other trials we've done in recurrent glioblastoma, and the trial failed to meet its primary endpoint. However, what we found out was that 2 patients who actually had the privilege of treating myself did extremely well. One patient had a progression-free survival of 18 months, and the other patient has a progression-free survival which was north of 30 months. Next slide, please. When we performed the correlative studies, which was led by Lisa Rogers, who was at University Hospitals at that time point, and has now moved on to Henry Ford, was that the MPG staining was negative in 6 patients, was 1+ in 5 and 2+ in 3. and the progression-free survival of more than 11 plus months in 2 patients was associated with the MPG expression. We found out that the combination was safe and was fairly well tolerated. We only saw 2 grade 3 to 4 toxicities, which were lymphopenia and thrombocytopenia, which is common toxicities which see with temozolomide. Next slide. But what was very interesting from this trial was that median overall survival in the Mgmt patient population was 30 months. Now, we only had 5 patients in the Mgmt methylated group, so it was a small number. Mgmt unmethylated was 9.9 months. So there, now intuitively, the double hit hypothesis is standing out here. So if you have single hit with Mgmt methylated tumor and you do a base excision repair inhibitor, you're providing a double hit, and that's where you're seeing the most promising outcomes. Next slide, please. What we did was we also had tissue on these patients, and we did a collaboration with Mike Perrins, who's at TGen in Phoenix. And what Mike did was he looked at the DNA as well as the RNA. So he did RNA transcriptome analysis. And what we found out was we had this signature, which you can see on the right side of the image here. The 2 patients, can you click once more, Lacey? Yeah, so these were the 2 exceptional responders who had progression-free survival of 18 months and overall survival of 32 months, and the progression-free survival of 30 months and overall survival was 39 months counting when we did our last analysis. And both these patients who did extremely well had a gene signature on this 44 founder gene sets, which were the hallmark of DNA repair gene set. And then there was 1 patient who had a borderline signature, which you can see in middle. That patient actually did well for 6 cycles and progressed after 6 cycles, but was short of the PFS 6. So, which gives us a lot of excitement that we may have a signature which can be validated. Next slide, please. What we also found was that the responder patients showed overactivation of the chromosomal instability signature and proliferation signature. Next slide. What we also found with this work was the response to TRC102 was independent of the other molecular subtypes. Next slide. And when we went back and looked at what percentage of patients actually have this gene signature, which is the hyperactivation of the DNA damage response signaling based on the 44 gene sets that I talked to you about, basically is 10% of TCGA has this signature. And we treated 19 patients and 2 of them had the signature. So which was very comparable to the 10% of patients who have this signature. Next slide. So on the basis of this, we have built a phase 1/2 trial that is going to go through the auspices of SWOG, where we are combining TRC102, but we are taking it in the upfront setting, because we also know in oncology that once resistance sets in, it's difficult to reverse it. So this will be Mgmt promoter methylation. GBM patients will go on to get temozolomide and radiation as per standard of care, and then we'll add TRC daily, and we'll start out the dose level of 75 milligrams per day. And then we have built in a dose level 1. Can you go to the last slide, Lacey? Sorry. And essentially, we will validate the DNA damage response pathway in the prospective manner. So with that, I'll stop. And if there are any questions, I'm happy to take it. And again, Dr. Eric Wong will moderate it in the room, and then we'll take on questions virtually.
Well, thank you, Mamit. Anybody here has a question?
What are the side effects
Okay, so the question is, what are the side effects of TRC102?
Okay, great question.
Elaborate.
Yeah, no, absolutely. So the primary side effects of TRC102 are actually myelosuppression. But in the 19 patients that we treated, the drug was extremely well tolerated. No patient actually discontinued the drug because of toxicity. The only grade 3 toxicity that we saw was thrombocytopenia and lymphopenia, as I alluded to. And otherwise, the drug was extremely well tolerated. I actually treated 10 patients myself, and my colleague, David Pierboom, had treated another 4. So of the 14 that we treated just at Cleveland Clinic, all the patients did well. Now, obviously, some patients went off it in 2 months, but the patients who stayed on 4 months or even longer And the 2 patients that I treated who were exceptional responders actually got the drug for 12 months and did not have any dose delay. So overall, fairly well tolerated. Now, obviously, in the upfront setting, it'll be a different aspect because we'll give the drug a little bit more, especially with radiation. And that's why we are building in these 2 dose levels. If there are no other questions from the room, any questions virtually? If not, then, obviously I will present this concept again, and we'll have these concepts discussed in the working group as well, which will have a meeting. But in the interest of time, I'm going to move on. And the next presenter for us today was Dr. Justin Lathia was going to talk to us about leveraging laboratory observation for the next generation clinical trials. Justin had a last minute conflict. So Daphna Baek, who works with Justin Lathia, and I've had the privilege of working with her, is going to give the presentation on Justin's behalf. Daphna, the floor is yours.
Thank you very much. So Justin apologizes that he wasn't able to attend this meeting, but I will briefly talk about our lab's goal of translating basic research findings into clinic. Next slide, please. So our lab is interested in cancer stem cells and how they relate to tumor. And along this axis, we have several emphasis areas. Next, please. We study microenvironment interactions by looking at cell adhesion as a potential pathway. Next, please. Study direct cell communication that is mainly mediated through gap junctions. Next, please. We work on niche factors such as ADAM-DAX signaling and asymmetric cell division. Lipid metabolism as a potential regulator of cancer stem cells, and their interactions with the immune microenvironment with regards to myeloid-derived suppressor cells. So the purple journals are indicated, the purple manuscripts that are indicated in the slides are posted to preprint. So we are a true believer of collaboration and open access. But in today's talk, I will mainly focus on 2 areas, which are lipid metabolism and myeloid-derived suppressor cells. So next slide, please. So the question arose in the lab was how cancer stem cells can interact with the immune system to suppress anti-tumor immune response. Next, please. And one axis is myeloid-derived suppressor cells, a heterogeneous population of immune suppressing myeloid cells that are classified into monocytic and granulocytic subsets. And we wanted to understand whether these cells can serve as biomarkers of disease and to understand the individual contribution of subtypes into the disease progression, with the ultimate goal of developing therapeutic targets. So the results that I will present today are mainly generated by a former PhD student, Tyler Alban, myself, and neurosurgical resident Valentat was in collaboration with Dr. Manmeet Ahluwalia and Mike Vogelbaum. And the ultimate goal in the lab is to better elucidate this mechanism, how cancer stem cells communicate with immune lineages, different immune lineages, and whether we can identify signaling modalities for therapeutic targeting. And mainly we focus on PMN MDSCs and monocytic MDSCs, the 2 cell populations that are shown on the right side of the slide. Next, please. And these are immature myeloid cells that are generated in the bone marrow. And when monocytic MDSCs are slightly different from monocytes, and similarly, polymorph nuclear MDSCs or granulocytic MDSCs are different from neutrophils. But these populations all play a role in the tumor microenvironment. But it is certainly unclear how these cell types are distinct, what kind of role they play in the pathological state, and especially how they function in the context of cancer. And to better understand this, we've done an single-cell RNA sequencing in collaborations with Dr. Antonio Ivarone at the Columbia University, and really looked into the expression profile of monocytic MDSCs and granulocytic MDSCs from blood and tumor in more detail. These assays suggested that these cell types are quite distinct from one another, but monocytic MDSCs do resemble macrophages to a very certain degree because they share the same lineage. But how do they look in patients? So our results have shown that myeloid suppressor cells are elevated in patients with glioblastoma compared to patients with benign lesions. Furthermore, these increase in the MDSCs correlate with patient outcome and disease progression. These results were published back in 2018, and we identified immune signatures that correlate with increase in myeloid-derived suppressor cells and that associate with poor patient outcome. So these results were led by Tyler and Balin. But to better understand how this increase could be a potential therapeutic target, we turned into our preclinical models and to use the syngeneic mouse models where we injected 5-fluorouracil IP on daily basis. Next, please. And looking into increase in the frequency of myeloid-derived suppressor cells, we actually observed a dose-dependent increase in the percentage of these cells in preclinical models. And this link was linked to reduced tumor burden in our mouse models. Next, please. And correlated with increased median survival duration. So this targeting of MDSCs was important because it was altering the immune microenvironment with specific increase of CD8 positive T cell frequency and reduced regulatory T cells, suggesting that we were generating anti-tumor immune response by targeting MDSCs using chemotherapy agent. And next, please. And these were basis of the clinical trial that was run by Dr. Vogelbaum, in which we treated patients with oral form of 5-fluorouracil capecitabine to prevent post-surgical increase in MDSCs. And here you can see the newly diagnosed patients in black, and we tested 3 doses of capecitabine and measured the frequency of MDSCs over time. Next, please. And looking into changes in the MDSC frequency, what we observed was a dose-dependent reduction in the frequency of these cells in patients undergoing surgical resection. And this is really important because MDSCs do correlate with worse patient outcome, and that is including chemotherapy outcome as well as checkpoint inhibitor outcome. Here is shown for ipilimumab in the context of melanoma patients, but in a pilot study here at Cleveland Clinic, when we look at the glioblastoma patients that was treated with checkpoint inhibitors, we did observe the increased frequency in myeloid-derived suppressor cells in non-responders. And currently, we, in collaboration with Dr. Ahluwalia, we are trying to understand immune signatures that associate with that. But that really speaks to MDSCs in broad. So what about the specific subsets, monocytic versus granulocytic subsets? And this is the study that I led as a postdoctoral fellow when I joined Justin's lab, where we tried to understand different immune signatures in males versus females with regards to myeloid-derived suppressor cell subsets. And our observations stem from the differences in survival. Looking into syngeneic mouse models, we observed that male mice with tumors succumb to disease earlier than female mice with tumors. And this is transferable. If we do bone marrow transplantation experiments and basically transfer male bone marrows into female recipients' mice, we observe accelerated disease progression. And this is basically the confirmation that we are changing the myeloid-derived suppressor cells. So this really suggests that there's an immune basis for it. But what about in patients? So if you look at the survival across age groups in glioblastoma patients, we see a quite distinction. And Justin always likes to emphasize what is the basis of this. Next, please. Is it a mutation? Is it an environmental factor? But in this case, it is sex. We observed that males constitute 60% of all GBM patients. And furthermore, next please, when adjusted for relevant confounding factors, we observed that male patients have a worse outcome than female patients. And this is an ongoing consortium effort where we are trying to better understand the sex differences in glioblastoma and how we can target them. And this study read by Josh Rubin suggested that male versus female cancer cells might be susceptible to different drugs at different degrees. But again, going back to the immune basis, next please, how is that related to? So since we have established that MDSCs are important, what we did was in preclinical mouse models, we tried to target these cells using depletion antibodies. We tried to deplete monocytic versus granulocytic MDSCs. Importantly, we were not effectively depleting monocytic MDSCs in female or male mice, so we didn't see any change in the survival outcome. Next, please. But when we actually look at the targeting of granulocytic MDSCs or MDSCs in bulk, we observed a better outcome in female mice treated with this drug regimen compared to male mice, suggesting that there is a basis for different targeting in males versus females. And we observed this across multiple models. Next, please. So these are depletion strategies that are not applicable to patients. So what about, how can we translate that? Next, please. We perform gene expression analysis and perform drug prediction algorithm using this differentially expressed genes. Next, please. And observe that chemotherapies could effectively target monocytic MDSCs as opposed to the IL-1 pathway inhibitors that can more effectively target granulocytic MDSCs. I like to highlight that our previous clinical trial was with capecitabine, but fludarabine was predicted to be more effective against monocytic MDSCs. Next, please. So we tested this in our in vivo models and observed that fludarabine treatment extended survival in male mice with tumors, but not female mice with tumor. It's consistent with more monocytic MDSC prevalent activity we observe in this sex. In contrast, neutralization of IL-1 beta was more effective in females compared to males. Again, that was more related to increased granulocytic MDSCs. What are additional mechanisms that can target MDSCs? So this suggested that there was a difference in males versus females, but we wanted to understand the basis of it. So to do so, we did adaptive transfer experiments and transfer monocytic and granulocytic MDSCs in tumor-bearing mice to see how they affect disease outcome. Next, please. This result suggested that in males particularly, transfer of monocytic MDSCs, increasing the cell numbers, significantly accelerated the tumor genesis, that is the blue line, compared to the black line, whereas transfer of granulocytic MDSCs did not have such effect, orange line compared to the black line. Next, please, if you could go back. So that's we really wanted to understand this better, and that's why we studied the epigenetic basis of this as two cell subsets and identified that these cells were characterized with different epigenetic marks. In particular, looking at the genes that were more accessible in monocytic MDSCs, we observed that cell-related pathways were active in this cell compared to the granulocytic MDSCs. Next, please. And along these lines, we observed that monocytic MDSCs had higher levels of integrin beta-1 and beta-7 expression on the surface of the cells, and that was both in blood, bone marrow, and both blood and bone marrow, where they were generated and where they were trafficked. Next, please. And these are relevant expression levels, so we wanted to understand the functionality and use the specific antibody that recognizes the active form, and again observed higher integrin beta-1 levels in monocytic MDSCs compared to granulocytic MDSCs. And we were able to validate these using human specimens. Looking into blood and tumor, we observed again in patients this time that monocytic MDSCs had higher levels of integrin beta-1 compared to granulocytic MDSCs, whereas our preclinical observation with regards to integrin beta-7 did not translate into patient setting. And again, using publicly available single-cell data sets, we further validated it across numerous patients, and again observed that monocytic MDSC subset has higher levels of integrin beta-1, but also beta-7 expression levels at the RNA level compared to granulocytic MDSCs in patient tumors. Next, please. We wanted to understand the therapeutic relevance of this integrin expression. And to do so, what we did was to perform adaptive transfer experiments again, but this time we block integrin beta-1 on the surface of monocytic MDSCs prior to adaptive transfer. So as expected, isotype-treated monocytic MDSCs accelerated tumor genesis, that is blue line compared to the black line, whereas blockade of surface integrin beta-1 completely abrogated this function, that is solid blue line compared to dash blue line. As expected, integrin beta-1 treatment of granulocytic MDSCs did not impact their function, but again, to our surprise, integrin beta-7 blockade had no effect either on the functionality of monocytic MDSCs, further highlighting specific role of integrin beta-1 in pro-tumorigenic role of monocytic MDSCs. And this was actually, if you could go back one slide, this was mediated through immune changes in the tumor microenvironment. And specifically, what we observed was that when we increased the levels of monocytic MDSCs, there was an increase in the tumor-associated macrophage frequency, whereas when we block integrin beta-1 on the surface of monocytic MDSCs, we were not seeing such increased macrophages. Next, please. So overall, these studies suggested that the epigenetic programming of immune cells could be next-generation therapeutic targets. Specifically, we observed that monocytic MDSCs have higher levels of cell adhesion pathway, these genes were more accessible, and they were responding to integrin beta-1 signaling. This was through modulating the tumor microenvironment. Next, please. Currently, we are trying to understand binding partners of integrin beta-1 and testing clinically relevant inhibitors to modulate this activity. Next, please. So what are our ongoing studies and some future perspectives? As I mentioned, we are actively trying to identify additional targets against MDSCs to use in combination with immune activating strategies. Our goal is to reduce immune suppression in the tumor microenvironment to make it a more permissive environment for checkpoint inhibitors or other treatment strategies to work. And along this angle, we are hoping to use canakinumab and an anti-IL-1 beta inhibitor in collaboration with Dr. Ahluwalia to test in patients with glioblastoma. We have some recent collaborations with Dr. Friedman Morvinsky and Mellenhorst to develop CAR T cells and use them in combinations with myeloid-derived suppressor cell targeting strategies. Next, please. We are a basic research lab with strong clinical collaborators. So our ongoing goals include using this clinical trial specimens to identify signatures that associate with response or non-response so that we can develop better therapeutic targets. We are currently trying to understand the lineage relationships between monocytic and granulocytic MDSCs so that we can better manipulate these cell subsets, and expanding sex differences of observation into the other immune cell populations with regards to T cells. Notably, there is a new postdoc in our lab, Ju-Yun Lee, who has very beautiful data showing that there are sex differences in T cell response as well. Next, please. And maybe one quick note, what are the other potential factors? That is something that regards to the lipid metabolism that I mentioned earlier. Next, please. Obesity is a risk factor in context of glioma and women, suggesting that host factors could play additional roles in the regulation of immune response, but also disease biology in general. Next, please. And a postdoc in our lab, Dan Silver, recently published this beautiful study where he studied the impact of high-fat diet. And he observed that when animals are fed with high-fat diet, they succumb to disease earlier than animals that are fed with low-fat diet. Next, please. And he beautifully outlined the metabolism, but one note from this was high-fat diet reduced hydrogen sulfide levels. This is a gas that is a mediator of protein modification. And he linked this mechanism, outlined this mechanism beautifully, showing that the effect was through reduction of hydrogen sulfide reduction in the context of high-fat diet. Next, please. And this is important because there are ways to increase the levels of hydrogen sulfide. And one potential way to do this is propylthiouracil. And this is, again, clinically approved drug that could be repurposed easily. And there was a small study that was led by Jean Barnett, and they had shown favorable outcome. So one of our ongoing efforts is to translate the PTU to boost hydrogen sulfide and use this as an anti-cancer mechanism. Next, please. So with that, I guess Justin would like to thank all the laboratory members, and this is some of us since 2012, and I would be happy to answer any questions you have.
Thank you so much, Daphna, for filling in for Justin and to give you an overview of all the exceptional work you and your group are doing. We'll again do the same tandem. We'll start with the room. If there's any question, Dr. Eric Wong will moderate.
Any questions in the room? Nope. No one.
None. Okay, great. Any questions virtually? If not, thank you so much, Daphne.
Thank you very much.
While we'll transition to the next speaker. I just had put in a comment in the chat box. Please add your name and your email in the chat box so Lacey can add you to the email chain that we'll create for our working group. And meanwhile, I might just ask Dr. Eric Wong for one more thing. Eric, if there's any paper in the room and people who are attending, just if you don't mind, just having people sign in with their emails and take a picture of that and email it to me or text it to me, because I really want us to move, get this working group in motion rather than just us meeting, every 6 months, because we need to get more energy and momentum going with that. And in terms of our next speaker, I would like to invite Dr. Yasmin Odia, who's the Director of Neuro-Oncology at Miami Cancer Institute. She's going to talk to us about her concept in phase 1/2 trial of selinexor and Pematroxide for relapsed and refractory primary CNS lymphoma.
Thank you so much for the opportunity, Dr. Ahluwalia. I present this phase 1/2 trial of selinexor plus Pematroxide for relapsed and refractory CNS lymphoma next. These are my disclosures, none of which are of interest for today's talk. On behalf of my co-investigators, I start off the talk next with the rationale. Despite a high dose of methotrexate-based regimens, many patients relapse and then die of their primary CNS lymphoma. There is, in fact, no standard of care at progression or relapse. Pematroxide is, however, an NCCN-approved salvage therapy for these patients. Selinexor, which is a first-in-class small molecule inhibitor of exportins or SINE, has shown activity in refractory and relapsed systemic diffuse large B-cell lymphoma, which represents the overwhelming histological subtype of primary CNS lymphoma. Selinexor has established CNS penetrance, and I'll show you two studies that show this. And third, finally, selinexor efficacy in CNS lymphoma does warrant further study next. So Pematroxide is a multi-targeted antifolate similar to methotrexate, which is, as you know, the core of the primary treatment in these cases, but it does have a broader spectrum of activity. Single agent activity has been shown in various studies, but I highlight what will be the historical control by Razor and all, looking at Pematroxide in the treatment of relapsed and refractory CNS lymphoma next. In this study, the median age was approximately 70 years with a KPS of 70%. And in fact, 10 out of the 11 patients had failed prior high-dose methotrexate. They were dosed at 900 milligrams per meter square, which is obviously higher than standard for lung, but still every 3 weeks, with dexamethasone, folate, and B12 supplementations. The treatment cycles were defined as 6 weeks, that is 2 doses, until complete remission, progression, or toxicity. And there was a median of 5 cycles, that is 10 doses received by patients. The objective response rate in this cohort was 55%, with a disease control rate of 91. The progression-free survival at 6 months was 45%, with a median PFS at 5.7 months and a median OS of 10.1 months in usually patients with very dismal prognosis. And the toxicities were mainly were hematologic and infectious, higher in rates due to the higher dose compared to non-small cell lung cancer cohorts next. These are the Kaplan-Meier curves of both the PFS and the overall survival. And the toxicities by grade, I highlight that the grade 4 toxicities were mainly anemia, leukopenia, and thrombocytopenia. These were also obviously seen in grade 3. In addition, fatigue, liver enzyme abnormalities, and infection were also noted. Next. So again, selinexor is a SINE molecule, first in class, and in fact, it's a selective inhibitor of exportin-1. It's an oral drug administered 1 to 2 times per week, usually day 1 to 3, depending on the regimen. There's no known drug-drug interactions, and so this allows it to be studied in combinatorial regimens. There's numerous patients. This is now in a dated slide, so there's even a greater number of patients treated with selinexor alone and in combination across tumor types. And in particular, I jumped to the side effects of anorexia, nausea, fatigue, which are popular with this drug, but also platelet, which is a cross toxicity with Pematroxide. But we'll describe some of the supportive care. In the end, the first approval was a myeloma, but since then it has been approved in multiple entities, including systemic diffuse large B-cell lymphoma at recurrence. Next. As stated, this is a exportin-1 inhibitor, and as such, it is involved in controlling the transport of tumor suppressor proteins between the nucleus and the cytoplasm. Next. Its main activities, therefore, is G1, G2 arrest. And in terms of other cancer-related processes, it seems to regulate, includes progression, apoptosis, metastasis, and drug resistance. It seems to have a linear PK across multiple doses. Next. And in particular has shown blood-brain barrier penetrance. This is in a preclinical model. I'll show you some evidence supporting CNS penetrance in human studies, in particular clinical trials. Next. The evolution shows an increasing number of studies. If we put in there 2021 and 22, there are numerous additional trials in multiple entities. Next. Next. And so I highlight the key studies relevant for this presentation, which includes the recurrent diffuse large B-cell cohort, which is the SADL study, and its dosing was actually 60 milligrams twice daily, and the toxicities of note, thrombocytopenia being by far the highest in propensity and frequency. However, other cytopenias were also noted, including anemia and lymphopenia and neutropenia. Mild electrolyte abnormalities were also noted, but grade 3 and 4 in some cases. And also noted, but not listed here, as these were the laboratories, fatigue and anorexia were also common. Next. This is the survival curves, the red curve being all patients across study. But if you note, the top curve is the patients who had a complete or partial response, who had not reached a median overall survival in a median follow-up of 14.8 months, and a waterfall plot that shows some degree of activity in systemic diffuse large B-cell lymphoma. Next. In terms of CNS penetrance, really the studies to date involving selinexor have been in glioblastoma. The King study looked at recurrent GBM and ultimately selected a dose of 80 milligrams once a day as a highly efficacious and tolerable toxicity. And as such, this became the recommended phase 2 dose. Next. Which in fact was used in this study, the export GBM 029 study, which is looking at, in the first 2 arms, newly diagnosed glioblastoma by Mgmt methylation status. Patients with methylation receive temozolomide and selinexor. Those who have Mgmt unmethylated then receive selinexor alone with radiation. The recurrent arms were combined with various agents, all of which are being actively studied and in interim analysis right now. But this study again supports the notion of CNS activity of selinexor. Next. In terms of experience with primary CNS lymphoma, there's in fact no active accruing study. This is one of the studies intended to fill that gap, looking at primary CNS lymphoma, in this case recurrence. And we highlight a case report of a 55-year-old man who had had multi-recurrent systemic diffuse large B-cell lymphoma, German essential type, and had failed multiple lines of treatment, including stem cell transplant, but recurred in the CSF, had received combinatorial methotrexate-based regimens after 9 cycles, but then had CNS recurrence, now parenchymal as well as CSF, and then applied for expanded access of selinexor, being dosed in the diffuse large B-cell dosing of 16 twice weekly. Next. And in this patient, you see that there was a complete response of a right cerebellar lesion and a near complete or partial response of a left lenticular nucleus. However, due to toxicities, in particular fatigue and anorexia, there was a gradual dose reduction and ultimately discontinuation, after which his tumor did recur in the CNS and was the cause of his demise. Next. As such, we then propose a phase 2 study with a lead-in phase 1 of selinexor and pemetrexate for relapse refractory. We would dose it at the 900 milligrams per meter square in terms of pemetrexate every 3 weeks in 6-week cycles. Selinexor, 2 dose levels will be studied, starting at 60 once a week and ultimately aiming for the 80 once a week of CNS penetrance dose that was determined in the GBM studies. Consolidation regimens are simply suggested, but at the discretion of the investigators, and maintenance selinexor is offered to patients who have not received stem cell transplant, if they so wish it, at the discretion of the investigator. And once again, I think baseline testing is a standard of care for primary CNS lymphoma in terms of staging CNS and systemically. The phase 1 portion is a 3+3 design, starting with the 60 milligrams once a week with a maximum of 12 doses, and noting that any patient that is treated at the recommended phase 2 dose will be included in the ultimate analysis. Next. In terms of statistics, again, this is a single-arm, open-label phase 2 study with a lead in phase 1. In terms of sample size, it's based on a one-arm binomial using a null or a historical ORR of 55% based on the RAZOR study, with a goal ORR of 75% with normal, with standard alpha 5% and power of 80%. As such, we need 35 patients eligible and estimate to enroll about 40, assuming a 15% attrition. And of note, and as a reminder, the ORR is based after the induction phase only, and as such, the other endpoints secondary to consolidation, et cetera, are really secondary analyses. Next. The response criteria are standard based on the International Primary CNS Lymphoma Collaborative Group. Next. And knowing now the data supports prophylaxis for some of the toxicities associated with selinexor. There would be a dual antiemetic to start with close monitoring for nausea, hyponatremia, fatigue, which is often treated either with steroids or stimulants, and cytopenias that can be simply managed by treatment holds, transfusions where needed, or bone marrow support when warranted. No, thank you. Any questions?
Thank you, Yaz, for all your great work on this. So we'll follow the same pattern. Dr. Eric Wong will moderate any questions in the room first.
Okay. Anybody has question? Nope. Mamit, we don't have a question.
Yasmin, this is Fabio.
Yes.
Hi.
How are you?
Very nice presentation, and I agree this will be an interesting combination. I mean, I think the one thing they tried, I think, carbopemetrexate in solid tumors and with selinexor, and the issue was myelosuppression. And in the same thing with in the GBM, the selinexor has been challenging for the same reason.
Mm-hmm.
In the carbopemetrexate, I think the pemetrexate was at 500. I think the recommended phase 2 dose ended up being 40. So you may want to add, lower doses in case.
Yeah.
I think
like dose de-escalation.
Yeah, I think the other thing as well is, this pemetrexate study is quite small, and so meaning that the ORR or 55% has a huge confidence interval.
Mm-hmm.
I don't know how you're gonna deal with that, because of course 75% is quite a high target for.
Mm-hmm.
to call the study positive or not.
So is there suggestion to get a
I'm not sure it's worth based on a study that has 11 patients or so.
Mhm.
Because it's just, 55% on, the confidence interval could be between 10% to whatever, 80%. So it's just hard, I think. I mean, one thing would be to maybe look at the historical data in some ways of responses that are durable, and see if it will be a lower, because even in that curve from Jeff Razor's study, I think the, really past 6 months was only about 25%, and that the PFS was still ongoing. I mean, these are things for you to think, because it is a pretty high number.
It is. I think part of the reason, and I appreciate your comments, I don't know if it's best addressed by either maybe getting a better estimate of the ORR across multiple studies and using that. That might be.
Because even if you look as, like ibrutinib that has also high responses, or that even that Tensor study that have a very high response, but it's not durable at all. So if you could come up with that it's, ORR with durability of at least, X amount of months, and see how historical data, because otherwise I think this combination may have activity, but you have such a high target that
it might be an unrealistic aim. The only other concern I had, and why I shied away from any time-based response, something like PFS6, is because we were focused only in the induction. And I think if you start only doing time points, it's going to include consolidation, and then it's going to, I think, murky the water, which is why I was trying to stay to a response endpoint.
I see. Yeah,
because then we have to mandate, I think, the consolidation and homogenize it.
Exactly. Yeah, that's a good point then, because the durability of response will be dependent on the post-induction consolidation. So.
Correct. So maybe if we can start by maybe looking at what the ORR is on various other studies and see if we can find a reasonable target that is supported across the studies.
Yeah, I mean, just things for you to think.
No, I think that's a great point, Fabio. And what I would just add is, so as we get into our working group meetings, maybe we'll have you present the concept there and maybe add some of the information. And we can use those opportunities as informal sessions to brainstorm and add value. And we'll also, working with Dr. Kurzrock, we are adding a statistician who'll be available for those meetings as well to help us, take this concept to the next level.
Great, thank you so much.
So thanks so much, Dr. Odia. Last but not least, Dr. Tony Wang, who's a professor of radiation oncology in Columbia in New York, is going to give us a overview of his concept phase 2 study of atezolizumab and tocilizumab with radiotherapy in patients with newly diagnosed unmethylated Mgmt promoter.
All right. Thank you, Dr. Ahluwalia. Thanks for the opportunity to present this concept at SWOG. I've really got a lot of great feedback in the last prior meetings, and I've really incorporated some of the changes to this concept. And so this is a study that's also done with Dr. Iwamoto, who was just asking a question earlier. Next slide, please. Oh, I'm sorry. You know what? Apologies. Back to that slide. So as I have shown before, some of this work has been done primarily from our colleagues at Northwestern at Penn, is the role of anti-IL-6 microantibodies. And this study that I'd shown before, this is a murine model, orthotopic GPM murine models that used anti-IL-6 monoclonal antibodies, was shown to improve survival in these in this control group with IL-6 in combination with CSF1 or by itself, which is the wild type IgG. Next slide, please. So again, this is a study that I presented from Lamano in 2019 that looked at anti-IL-6 therapy, which was really shown to help reduce CD68 myeloid cell infiltration, as well as increase CD8 positive T cell infiltration. Next slide, please. So in this study, again from our colleagues at Northwestern, what they did was they did a anti-IL-6 and an anti-PD-1 combination treatments for these synergistic C57B 6 mice, where they injected the GL261 implantation at day 0, followed by antibody treatments about 1 week post-implantation. The injections were either given by placebo or anti-IL-6 monotherapy, or PD-1 anti-PD-1 monotherapy, or a combination of anti-IL-6 and anti-PD-L1, followed by immunophenotyping and then a survival analysis. And as you can see here on the bottom left figure from their study, when you looked at the actual response rate by tumor reduction, the combination of anti-IL-6 and anti-PD-1 appeared to have a reduced tumor, greater tumor reduction over a period of about a month. Also, when they looked at tumor volume, again, just to the right of that figure, you can kind of see that in the tumor volume reduction over time by the treatment arms was more pronounced with the combination of anti-IL-6 and anti-PD-L1. And then, of course, on the bottom right, you can see that there's actually, based on just survival curves alone, and there were approximately about, I think there were about 7 or 8 mice per arm, that in terms of survival, the combination of anti-IL-6 and anti-PD-1 was associated with approximately 2 months versus 1 month with monotherapy alone, and then approximately 2 to 3 weeks with just in the control group. Next slide, please. So this is a concept that I proposed before, looking at where we're looking at specifically for patients that have unmethylated Mgmt. And as Dr. Alawali may have alluded to, and many of us here in this meeting know, the unmethylated Mgmt are not generally responsive to temozolomide. If you look at the post-hoc study from New England Journal of Medicine, the addition of temozolomide is associated with less than a 3-week survival benefit for those in the unmethylated Mgmt GBM cohort. And so what we're looking for specifically are patients with newly diagnosed glioblastoma who undergo maximal safe surgery, and based on some of the previous studies that I presented before, to get a combination of radiation therapy followed by atezolizumab, which is your anti-PD-1. This is from Genentech, as well as tocilizumab, which is an IL-6 inhibitor, followed by adjuvant atezolizumab and tocilizumab. The radiation therapy is fairly standard, both for NRG and other cooperative group treatment would be 60 gray and 30 fractions. The dosing that's being recommended here, again, also courtesy of my co-investigators, is to use it based on some of the current ongoing GBM or recurrent GBM trials with this type of dosage. And this is specific for unmethylated Mgmt, have to be adults, and you'd have a decent KPS. Our primary endpoint is to look at the 1-year overall survival. Based on unmethylated Mgmt GBM patients who generally do poorly the methylated, the 1-year overall survival we expect is to be 50%, projecting a 70% 1-year overall survival benefit. And based on 8% power and a P of 0.05, we're going to require about 37 patients for this phase 2 single arm study. And we project accrual will take approximately 1.5 years, and then follow probably another 2 years after that. So I'm going to pause here. Other questions I had gotten previously to this was whether or not we would allow patients to receive Avastin if needed. And the answer is yes, which I did not really elaborate in this slide, but that is certainly allowed based on the prior meeting that we had and some of the feedback I got from other of our colleagues here. So with that, I think that's the end of my slide. I promise I'll make this quick, and I'm happy to answer any questions, if any.
Great, Tony. Thanks. I will follow the same pattern. Any questions in the room with Dr. Wong will moderate?
Yes, there's a question in the room, Dr.
Hey, Andrew Brenner here. So a real quick question, actually one, what is the timing you anticipate for this in terms of competing with BN007 as this almost very similar to BN007, which is actively recruiting right now. And I think many centers will have that as an option for these patients. Another one is, let me ask another one real quick and I'll let you answer both. The other one is the model. I think, we've seen repetitively with GBM that the majority of the immune infiltrating cells are not T cells. There is a very heavy burden of macrophages, a very hypoxic microenvironment, very immunosuppressive. And so, I don't see that these models can adequately recapitulate what we're seeing in our patient population in the actual tumors. So in terms of model adequacies, what would you comment on that?
Yeah, so thank you for asking, thank you for bringing that up actually. So it's a good question. I think first of all, to your first question, and correct me if I'm wrong, you'd asked about, ongoing trials that have some similarity to this. And you mentioned, I think it was NRG-BN007, which is for those that aren't familiar, that's the phase 2/3 open label study of IPI and Nivo versus Temozolomide in newly diagnosed Mgmt patients with unmethylated GBMs. And so, yes, that's a very good question. I believe I'm actually quite involved in that study as well. And that actually currently is accruing very well. I believe at the last update from CTSU, it's already accrued about 140 patients from its accrual target, I think about 485. So it's accruing very well. And I would say that for this study, this is actually a smaller sample size, about 37. So I don't, in terms of accrual, I don't foresee that's going to really be an issue. From what I understand, this study has actually accrued, the BN007 has accrued very well, correct me if I'm wrong, but, and so I don't think that would necessarily be an issue with the smaller sample size in this phase 2 arm. And to your second point, if I recall, you're just discussing about the modeling of it for, Andrew, would you mind just rephrasing the last question you had?
Yeah, it really has to do with what we know from prior immunotherapy studies that, the microenvironment is tremendously immunosuppressive. All the immune infiltrating cells are macrophages, M2 polarized macrophages, very hypoxic and not a hospitable immune microenvironment. And so the models that we're using, they're very small tumors. They don't recapitulate that, right? So I guess I'm just wondering.
No, I agree. I think, this study and many others in, using immunotherapies for GBM have been using GL26, which is a completely, more hypermutated, a hotter tumor. So GL261, really, I agree. It's not the ideal syndemic model for testing because most of the times it works in the laboratory using this model. So, but that's the data that.
Dr. Iwamoto, I just want to add that GL261 is a very, very immunogenic.
Yes, extremely immunogenic.
So it does not fully recapitulate what's going on.
In fact, it's quite the opposite, because the GBM is often, a very immunosuppressive microenvironment, as you guys mentioned. So, and that's why everything, all these immunotherapies work in these models, because it's just doesn't represent what happens in patients.
I think there's another person with a question, Dr. Aboud.
Yeah, Aurora Aboud, UC Davis. Thanks, Dr. Wang, the interesting concept. 2 quick questions. I will start with the first one. Is Optune allowed during the trial?
Yeah, that's a good question. I think you're not the first one to ask that. I think as per some of the other trials that have actually allowed it, I don't think it's going to be required.
Okay. And the other question, are you guys open for new sites, or you're going to announce that later?
I mean, we would certainly be interested in opening for new sites. We're, as Dr. We're going to work with the group here, and for sure that's of interest. But I think we're a few steps before that.
May I add just one more question, and that is in neuro-oncology, we try to stay away from single-arm phase 2 studies, and a lot of neuro-oncologists advocate for a randomized phase 2. Would you say a word about that?
Yes, I mean, I think that's a very good point. Again, this is in terms of the strategy. This is something that Dr. Ahluwalia we've been discussion about, and probably the next and Mamie, feel free to chime in here. But I think we're going to have a meeting at some point with CTEP in terms of next steps for that. I agree to your point.
So that's actually a great point, Eric, and so I can just tag along on that. So 2 steps here. We are having discussions with SWOG statisticians as well. The 2 concepts, at least if you look at the GBM concepts, one's methylated, one's unmethylated. The cooperative groups definitely prefer, since there is a lot of effort that goes in designing trials and operationalizing them, they prefer actually the randomized trials. So we do plan to use a strategy that worked well with the CTEP when we were part of the adult brain tumor consortium. So we will have a pre-submission concept call with them. And you know, those of us, I serve on the brain malignancy steering committee, and a number of people on the call have presented to the steering committees, and you can get very varied opinions, frankly, but we are very open. And if there is an opportunity to submit a randomized concept, that actually may be the preference. Now, also right now, this is a working group. So we share our resources with Dr. Kurzrock and her rare tumor committee. So essentially we are open. If we get a green light that, a randomized concept based on the preclinical data we have is something that'll be, appealing to CTEP, we can definitely turn around in terms of stats. And if they say, no, we would like you to get some safety signal with the, safety built in and get some idea of preliminary efficacy, because as was alluded, right, in our field, one of the challenges is the mouse models that we have, right? So they're not the best recapitulation. So sometimes they might flip around and say, oh, we want to see some evidence of preliminary efficacy. So I think we are very nimble. If given a choice, our choice is randomized trials, because that's what we believe in, is the best way to test any hypothesis.
Dr. Brenner has another question.
Yeah, one more about design. And I understand the desire to go straight into newly diagnosed, but you don't have data in patients yet with this combination. And I think that, the IV study provided some intriguing results in terms of prior to debulking, when you have some immunogenic cells there to maybe driving an immune response, and then debulking so that patients can tolerate long-term therapy. And I think maybe I would actually advocate that a randomized trial in the recurrent setting for patients who are surgical candidates would not only provide you with the opportunity to take advantage of that, but you need more basic science data, and you will have the opportunity to evaluate those tumors in a randomized setting in the recurrent for patients who go to craniotomy, because then you're going to get the tissue. And you've seen what we can do with the multi-omics these days with the resources available for patients on NCORP trials. So I think you might have not just a better opportunity for evaluating the combination in terms of immune response and driving an immune response, but also to evaluate the biology.
Andrew, right? You're talking about in the context of a recurrent glioblastoma. Is that what you're saying?
Well, I mean, you could try it in newly diagnosed, but it's challenging because they go straight to surgery and you have to have a diagnosis first. But yeah, I think a recurrent study with patients being candidates for surgical resection, getting it neoadjuvantly, and then after surgery. And
I'm wondering if you're referring to NRG-BN010. I'm sorry, Mamie.
I think it's NRG-BN010, like 10. So right. There is already an existing protocol, Andrew, actually, looking at the combination.
Yeah, so Andrew,
the same combination?
Yeah, it's actually, so believe it or not, it's a phase 2 that's also looking at the combination of tezotuzumab, and we've basically it's accruing 53 patients, and we've already accrued I think 3 patients, for which Dr. Yamoto and I accrued 3 of them to that study.
Yeah.
Yeah. So I mean, there's definitely something to that already. That's ongoing.
Yeah, Andrew, that study is actually being led by Steve Bagley from UPenn, and it's also coming from some of the data the UPenn group with Dr. Brem and Dr. Bagley were able to generate. But no, I think the point you bring on is great, which is drug surgery, drug trials, which are the window of opportunity trials, which can help you actually test combinatorial efforts, which are new to get basically translational and data as well, and not only that, but also then mirror that with the clinical responses as you see. And I think this is a nice segue for setting up these working group meetings in between, so that we can brainstorm these. And what we will do is going forward, we'll probably have at every meeting we'll probably just have one concept that will be presented, and then we'll have feedback from everyone. How can we beef up the concept or make it as foolproof prior to CTEP pre-submission to maximize the chances of bringing the best trial forward to our patients.
Great, we agree. I don't think there's any more questions here.
So if not, I just shared my screen. I hope you guys can see it. And 1 second, I'm just going to swap. So this just has my email and Lacey's email. So I know some people had signed in, some had put their emails in the chat box. I just want people to have this, and then please, if you have other people who would be like to be part of our effort, would welcome them. We would love to create this as a very open forum for people to bring concepts. And if people have concepts, we would love to make it a very collaborative effort. I would actually encourage everyone to, try to think of ideas. And then if someone has an idea, everyone should work together to make it the best. One of my hope and desires is to make it a truly collaborative group, and then and also make sure that everyone actually gets some kind of representation, whether it's in concepts, it's on a committee as we move forward, because it's a way for us to, bring the best trials forward to our patients and also grow our working group. And if we are successful, Dr. Blanky is very open to us having a CNS committee. So I think this is a great opportunity since we are going to have a fresh start. And I would welcome all your participation and your friendship on this journey.
Mamit, maybe you can elaborate a little bit how an investigator can bring a new concept to this working group. Do they write up something like a short paragraph or send it to you? Can you elaborate a little bit?
Yeah, no, absolutely. I think since we are small and nimble, we can do it in a number of ways. But I think the best step will be if someone has an idea, feel free to sketch 2 paragraphs or just start off with a broad trial design, and then get it over to me. We can always brainstorm, and then I would just like it a little bit formed before we bring it to the working group, because everyone's time is important. But it doesn't need to be too well fleshed out. But one suggestion I always give people as they have ideas, if you can also meanwhile secure some kind of interaction with the pharma company or the company that makes the drug, is always something that we found goes a long way. But if you don't have those relationships, we can all work together and help each other.
Great, thank you.
Any other comments from anyone in the room or anyone who's attending virtually? If not, I would again like to thank all the speakers for all their great talks today. Would like to thank everyone who attended for their participation, and would again like to thank Lacey for helping organize today's meeting, and also basically look forward to her organizing our group as we meet periodically. So I think I've gotten some names. We'll poll people on how frequently we need to meet. We'll like to be nimble. I'm presuming probably every 6 to 8 weeks may be reasonable. We have 2 meetings every year. So I would like to at least meet 2 times, if not 3 times in between those meetings, to continue to put forward our concepts and work through with the statistician and the CTEP. Thank you, everyone. For those who are in Seattle, safe travels. And for those who are attending virtually, be safe, and everyone have a great weekend.
In Manmeet. Can you hear me?
Yeah.
Yeah, I just wanted to ask, what is the next steps for us?
Yeah, so I am going to write a summary email. Why don't I call you and I'll let you know, because
Okay,
there are the people
sure.
on the call, but I'll give you a call and I'll let you know.
Thank you.
Hey, Mammy, on the same notion, should I just wait till for the next one with you, or?